Hello, everyone. My name is Chauncey Jones. We wanted to talk to you all a bit about robotics. So mainly my component of this is the regional portion. I think you already heard from Dr. Osborne and from his standpoint on the general anesthetic portion. Next slide. No disclosures of significance for this talk. Next slide. Goals and objectives, of course, we want to maximize benefit, minimize side effect and risk for these procedures in an outpatient setting so that we can get the patients mobilized and moving along very quickly. We want adequate and excellent perioperative pain control and early ambulation, both of those, which means that we need to make sure that we don't involve motor components. We want to minimize extra attachments to the patient, catheters, Foley catheters, etc., as well as nerve block catheters, and of course, minimize any risk. Overview. This is kind of the quick and dirty of this talk, just so that you get the most out of it. Our practice is to do an adductor canal nerve block for the femoral distribution, which is motor sparing. We also do a sciatic nerve block, but low volume, low concentration. And then other things that we're moving towards are superficial and deep genicular nerve blocks. Superficial genicular nerve blocks, also referred to as anterior femoral cutaneous nerve blocks, either in the day of surgery environment, or we're also have moved towards iovera cryoneurolysis to be done prior to the day of surgery. In addition to that, the supplemental periarticular blocks by the surgeons are very helpful as well. For our adductor canals, we typically use Exparel in the concentration that you see on the screen. And for the periarticular blocks, they also use the other 10 cc's of Exparel in the OR. Next. So total knee, just very quickly, anterior, we want the femoral distribution, the superficial and the deeps. Posterior, we're looking at sciatic and geniculars. Next. Block options. The list gets longer and longer as we develop and become more precise in the areas that we focus on. The main point is to get good coverage, but also to provide motor sparing. So we could do nothing. We could go from epidural spinal from the central nervous system to more peripheral nervous system, lumbar plexus, quadratus lumborum. But the bottom line is there's a few that we have honed in on that you've kind of already gotten a spoiler for. Next slide. And so the pros: effective, safe, efficient, early ambulation, extended pain relief, and something that's teachable and scalable to your practitioners, because we don't want, hit or miss blocks. We want very effective blocks that are very reliable. So our success rate is greater than 95% for these. And then we want motor sparing and catheter avoidance. Next. Block options. So the ones in bold are the ones that we tend to focus on. Some of our providers will do an IPAC block for the posterior distribution, and then others of us do low volume, low concentration sciatic. Main thing is selective nerves, periarticular, and then the cryoneurolysis is the newer addition in the last couple of years. Next. For the adductor canal technique, we're going mid-thigh. We want experienced providers doing this. But again, it is teachable, so you can have your providers that are not as capable to learn from the ones that are. 10 milliliters of Exparel or 133 milligrams with 20 mLs of 0.25% bupivacaine for a total volume of 30 mLs for this distribution. If you happen to be at a facility that does not have Exparel at your disposal, then we will consider or recommend 30 mLs of 0.5% ropivacaine with decadron and epinephrine to extend the length of that block as much as possible. We're in the mid-thigh. At the mid-thigh site is the highest likelihood of maximizing the most distribution of sensory distribution and minimizing the potential motor component of the quadriceps. The superficial femoral techniques, again, our ultrasound guidance, mid-thigh, experienced provider with 5 ml aliquots per site, either with Exparel combination or the ropivacaine. Primarily, we focus on the sometimes the lateral femoral cutaneous, depending on how far it tracks down, but typically the medial branch of the anterior femoral cutaneous and the intermediate branch. We also pick up the infrapatellar branch of the saphenous if necessary. Next. This is an ultrasound guided view. Deep in the screen, you have the femur. Then you have your vastus intermedius and rectus femoris, and just above the muscle layers in the superficial fascial areas, but deep to the fat area, to the adipose tissue, you'll see what I call little eyeballs looking at you. And you can track those and you actually see them track if you're scanning live. And those are the superficial branches. Next. For the deep geniculars, people are used to doing deep genicular radiofrequency ablations, but we get good outcomes when we supplement these blocks with the deep genicular blocks, particularly if the patient is having significant pain in one of those distributions. So currently, I don't routinely do, all the sites, but if a person has significant superior medial knee pain or lateral knee pain, then I will supplement for that purpose. And again, it can be used with your Exparel combination, 5 mLs per site, or 5 mLs of the ropivacaine combination. Next. Ultrasound guided is what we do for efficiency. We typically do most of our blocks in the preoperative area to maximize the efficiency of OR utilization. But lateral views just along the shaft where the epicondyle starts to flare out. You'll often see the vessel there, and then the nerves run right beside it. And we just go out of plane straight down to the os, and then back off the os and inject 5 mLs at each site. Next. Now we talked about cryoneurolysis. This is ultrasound guidance as well with experienced providers, catching the superficial femoral branches and as well as the deep genicular branches as well. The infrapatellar branch of the saphenous can also be targeted. Cryoneurolysis we would do prior to the day of surgery to get 50% or more pain reduction, which would significantly increase prehabilitation as well as rehabilitation over a 60 to 90-day period. So we still do our typical blocks on the day of surgery, but this supplements the entire perioperative experience as opposed to us just focusing on the day of surgery. There is a bundle for this procedure. So you do need to make sure that you get it done 11 days prior to the total knee date of surgery to make sure that you don't have overlap between the two bundles. Moving on now to the sciatic block. So some people do the IPAC block, which is just behind the posterior capsule of the knee. We find a bit better coverage when we do sciatic blocks, and we will do an ultrasound guided sciatic block with low concentration, low volume ropivacaine, which is the key for this. So 0.1% ropivacaine, 20 mLs with some decadron. On the picture here, you're looking at the subgluteal view. To the right is lateral, to the left is medial, and the bony protuberance that you see on the lateral portion is your greater tuberosity, and then your ischial prominence would be more medial, but it's off the view of the screen. So in the middle of the screen there, you see the sciatic nerve. The sciatic nerve has a very nice epineurium around it. And so if you inject this low concentration, low volume outside the epineurium, then you will get a very nice analgesic block without having a dense anesthetic block and resulting in foot drop. So we've tracked this out. We did some unpublished studies on it, and we've shown that if you even inject a few cc's in that epineurium, you'll get a little bit of weakness and foot drop, but outside of it, we get good analgesic without affecting ambulation. Next. This is a cadaver study that I did. It's unpublished, but it's injecting of dye where I injected a few cc's into the epineurium on the right-hand side, and you see that the dye spread throughout the fascicles of the nerve. And the other one, on the left-hand side, you see that there is no dye inside the actual nerve. In the background there, you see the dye was around the tissue of the nerve, and the outer epineurium of this nerve below my finger is bathed in dye. Next. The periarticular technique is done in the operating room on the surgical field by the surgeons, but it's a nice supplement to this. There are several techniques and explanations on how to do that, so we won't go into detail about that today, but the similar combination of 10 mLs or 133 milligrams of Exparel, 30 cc's of 0.25% bupivacaine, and then further diluted with preservative-free normal saline to minimize infection risk. A spinal needle is used, 22 or 25 gauge small volume spinal needle is used. The key to this injection is that unlike other local anesthetics, the Exparel does not diffuse into the tissue. So you do have to take your time and inject 1 to 2 milliliter aliquots throughout the lateral, medial, and posterior portions of the capsule. If you don't have the patience for that, then I would not suggest using the Exparel or develop the patience to do that. Otherwise, you'll not be happy with the outcomes. If you just want to dump some solution into those sections without taking the time to do it in 1 or 2 ml aliquots, then I would suggest just using a typical REC solution, which would be a combination of ropivacaine, epinephrine, clonidine, and ketorolac. This is an illustration of the diffusion that's usually seen with just straight bupivacaine on the left-hand side. Just a large injection in one spot will diffuse throughout the tissues, and you see a much less significant diffusion when you use Exparel. So the liposomal component of it allows it not to spread into the surrounding tissues. So overview again, when we're doing total knees, we do adductor canal, which is the most important, along with the periarticular blocks are the most important components. Secondary to that, if you have a robust person who's got a good prehabilitative fitness, then the sciatic nerve block is a very nice addition. We are a little cautious on the sciatic nerve block if we have elderly patients or patients who have high frailty risk factors. And then from there, we move on to superficial and or deep genicular blocks. The addition to that cocktail most recently has been the Ivera cryoneurolysis that we institute at least 11 days prior to surgery.